how many of you are doing fetal MRI but feel like it's not as organized or as collaborative as you'd like it to be? Okay, so that's a bigger number of hands. That was my situation. So I'm coming from Indianapolis, from Riley Hospital for Children, and I'll just take a minute before I get started into the lessons of these slides to talk about our background. So I have been there for a little while through training and then been on the faculty for several years, but about 5 or 6 years ago, we were doing fetal MRI. I guess we've technically been doing it for, 10 or 15 years, but 5 or 6 years ago, it was very scattered, and it was spread out among multiple centers in our campus. So there was some going on in the abdomen section, which tends to, like to be the owners of MRI, and some going on in the neuro section, and some going on in the pediatric section. But in general, it was sort of treated just as a routine exam and not handled in any special way. And I think that that was a difficulty. And a second difficulty was that there hasn't traditionally at our center been a very tight, close relationship between radiology and obstetrics. Not that there's been any problem, but just that, we work in different hospitals, we each have different routines and jobs, and so there wasn't a lot of communication. And then our MFM section sort of bottomed out. So we went from having about 10 or so MFMs to dropping down to 1.5. So about 4 years ago, we had 1.5 MFMs, which was a real shock to the system, a big departure, as these things go sometimes. And then we've been, in the last few years, slowly rebuilding that back to the point where we now have 12. So it's been a unique scenario, and I think it bears some lessons for all of us. So, when we're doing fetal MRI, it's usually not in isolation. It's part of complex, comprehensive care that's required for these patients. And it's usually a group of people who are coming from many different angles: surgery, obstetrics, pediatric subspecialties, neonatology. And one of the key things that we want to try and do, I think, as the people performing and interpreting and coordinating the MRI, is to try and draw all of those different diverse groups together, to be sort of the glue that brings everyone into the same room to the same table. So there's a picture of some of the people that I get to work with. And really, the opportunities are greater than the risks. But I think sometimes the mentality can be to focus on the risks. If you're not coming from a background of MRI, if you're a referrer and you're hearing your radiologist talk about, well, we can do this new thing, we can add all this stuff, there's sometimes a bias that this is a solution looking for a problem, or this is just a fancy new toy. I remember when we were in the planning stages a few years ago for developing our fetal program, the administrator of the hospital was talking to everyone and saying what was going to be part of the program, and they were saying, oh yeah, and we'll get your fancy bells and whistles like your fetal MRI. And I think that can be the mentality, and it's really dangerous if we allow that to be the perception of what we're doing, that it's just some new toy. Because I think there are really big advantages and opportunities, not just for diagnosis and treatment, but also for collaborative care of these patients. So really, I think the key themes, if there is one for this talk, is how we can build collegiality and collaboration. In other words, in what ways are we more than just people who work in the same hospital and have cubicles next to each other? What is meaningful about being medical professionals who are truly colleagues in a real sense? And I think that has a lot to do with the way that we view each other. The worst way, and I think this is something that's been recognized by a lot of people, the worst way we could see this project is as a competition. Maybe you do ultrasound and I do MRI, and we're fighting over the same patients, and we're trying to compete about whose technique is actually the best one, when in reality what we want to do is all see ourselves in the same role as patient advocates, but offering slightly different areas of expertise, slightly different benefits to the patient. So we really need to see ourselves as colleagues, and we need to be able to collaborate with one another. Not just in name or on paper, but really, truly be joining hands. So this is one of my favorite human phenomena that occurs. This is in Catalonia in Spain. These are the Castellers, literally human tower builders. So you can see people in the close-up photo stacked one on top of each other's shoulders, holding arms in groups of 4, and each layer counts as a tower floor. So this is a 1, 2, 3, 4, 5 level tower. This is something that's been going on for hundreds of years. UNESCO calls it an element of, human heritage that must be preserved. And they compete at building stronger and taller towers. And the record last year was 10 levels. No safety cords, no harnesses, no apparatus like that. You would think, oh my gosh, this is like extreme sports, auto racing. The fallout from this has to be horrendous, but there are almost no injuries. There are almost no incidents. It's astounding. And it's a kind of tower that I see as a metaphor for us. This is the kind of tower that I want to be building in a fetal MRI program. So I just want to spend a little bit of time going through a few lessons. I know that you guys are eager to see images, and that's coming, but lesson number 1 for me is that you have to have a close relationship with the key group taking care of these patients, and that's almost always maternal fetal medicine. So in our situation, we had a depletion of our section of maternal fetal medicine, but as they were rebuilding, I made it my job to get to know each of them very well, to make myself as much a part of the work they were doing and convince them that I wanted to assist and complement what they were doing, not compete, not take away patients, not substitute MRI for ultrasound, but really to collaborate. And not surprisingly, when you say that, people like to hear it. I want to help you. What can I do to make your job easier? That's not a difficult thing for people to hear. And I think that when we talk about imaging, we want to make sure we don't set up an adversarial relationship, and we need to use the imaging that the other side is performing. So Dr. Bulis mentioned how important it is to look at the ultrasounds, and that's really been my experience too, although there's obstacles to that. So maybe some of you come from a place where they're on different PACS systems. A lot of OB groups use a dedicated proprietary PACS for their OB imaging, which has pre-populated reports, and it helps them to generate their notes, and it's not going to populate on your radiology PACS. So we had to go a little bit out of our way to make sure we both had access to each other's PACS systems all the time, because it didn't make any sense for us to be doing parallel simultaneous imaging that was blinded to each other. But unfortunately, that is the reality sometimes. So we really need to be able to work closely with them. And a big part of working closely with them is making ourselves very available. So we hear it a lot in a broader sense in radiology about, adding value and being open and being visible. And I think it's never more true than right here in what we're trying to do in these complex cases, to be able to be available. Oftentimes when we're scheduling MRIs, we're doing it as part of a comprehensive care day. We're bringing a patient in. We have a lot of statewide outreach in Indiana because we're the only school of medicine in the state. So we have patients traveling from long distances. They come in, so they want to schedule the exam and then have a care conference right afterwards. So they need to be able to talk to us right away. And there's, sometimes a presumption that a fetal MRI is the most outpatient of all outpatients, the non-stat of all non-stats, because they're going to be pregnant for a while, and I'm going to take some time, I'm going to save this for Monday morning, get a cup of coffee, really dig into this study. And it's nice to be able to do that, but it's also really important when there's a sense of urgency. It's almost always on the part of the patient, their anxieties, their needs, their travel schedules, to be available. So I try to, this may be going a little far, but I have, all of the MFMs have my cell phone number, and they're not afraid to use it, not just to ask me about imaging that's been done, but oftentimes to find out when imaging doesn't need to be done. That's, something that we can really add is saying, in this case, you see a little dilated bowel. I don't know that we're going to add a lot, and I don't know that there's really anything that we can say that you guys haven't already seen. So there's situations where it's actually to nobody's benefit to do more imaging than necessary. And also, the collaboration and the communication really assists with follow-up. So these are two different patients, right? The fetal MRI is under the rubric of the mom. All the neonatal care is going to be under the rubric of the baby. That means separate MRNs and, in some ways, disjointed medical records. And maybe your systems already have a way of taking care of that, but if you don't, you need to find a way to follow up, because when you pull up that neonatal brain MR, it may not pull up the fetal MR as a comparison, when it would be really valuable to have the comparison right there. So one way to do this that we've tried to do is to build a registry of cases so that we can keep track of all of our cases, and then to actually assign medical record numbers to the fetus before it's born, and it carries that medical record number with it so that the imaging is able to be followed up on much more easily. Another way would be to maintain the independent status in the EMR, but to link it somehow. But if you don't have that, in many ways, all of the hard work we do at fetal diagnosis and care gets lost when you switch over to a new name and a new MRN as a neonate. The third thing that we did that I think was really valuable was to consolidate all our imaging. So here's a map of all of the sites that I interpret imaging from. Fortunately, I don't do it on my own. There's about 120 people that help me, but there's cases originally that were coming from anywhere and everywhere. Not all the time, not every day, but you can imagine how dilute the experience was at any one center. And the quality was quite variable, and the comfort level of the technologist was quite variable. So we brought it all to one place, to our main children's hospital. We said, it's a little bit of an inconvenience on the front end, but it's going to reap so many benefits on the back end. We need to do all our imaging in one place for these important complex cases where we can have expertise among the technologists and among the radiologists, and that's going to really be valuable. So it allows us to try to concentrate our experience and the technologist's experience. And we really need to be working closely with our technologists. This is not something you can do on your own because most of us, if not all of us, are not full-time fetal MRI imagers. We're doing other things too, and we can't just sit around and wait for the next study. And so we need to have technologists that can really be our partners in this. So for me, that meant spending a lot of time in MRI, developing the protocols, troubleshooting, figuring out how to deal with problems and artifacts, but also learning right next to the technologist and sort of developing a toolkit. If we see this kind of problem, here are some methods to attack it. Here's how we can deal with this artifact or this motion. And to build some protocols in, that are basic for the head, for the body, for the placenta, and you can tweak those, but also to have techs, super techs. Here's one of the techs I work with regularly, Nathan, and he is terrific. I mean, the quality of our images, I think, has a lot more to do with him than anybody else, certainly more than to do with me. And to have somebody there, especially as your program grows and you start doing dozens and then hundreds of cases, you can't be there all the time. And so having a super tech is invaluable. And then talking in a group about these cases, not independently, not each of us writing our note and then each of us checking up on everybody else's note in the EMR, but really sitting down and having time to talk about these cases is so valuable. Of course, the number one winner is the patient. But really, it's a service to each other. Because how often do neurosurgeons, cardiothoracic surgeons, urologists, neonatologists, radiologists just sit down in the same room at the same time and talk? OBGYNs, MFMs. Not very often at our institution. I don't know about you guys, but carving out dedicated time to do that has been invaluable. So we started a conference. Ours is Thursday mornings. Started out small. I got, a couple neonatologists, a couple MFMs to come. Now it's really grown, and it's almost a snowball effect. People have heard about it. They want to come. They want to be part of it. It's an exciting venture. We regularly have, 50 physicians that come to these things. We have an MFM fellow put up a PowerPoint slide of the patient, and then we pull up the MRI and the ultrasound and the echo and look at all of the images and discuss them. And it's such a multidisciplinary conversation. Ethicists, palliative care, genetic counselors, it's really, really valuable. And the conclusions, the resolutions we're able to draw out of that are so much better because of the contributions. So I think that that's good for us and good for the patients. And another thing that really is needed and desired, I think, by our patients, by the subspecialists who are ordering these studies, is knowing who really needs this. And there aren't formal appropriateness criteria out there. We have some of that for other areas of radiology, but in this setting, a lot of centers have just developed their own, and I think that's the number one thing that has made the MFMs and the neonatologists happy, is going through the most common diagnosis and developing a little bit of a list of here's why MRI might be valuable, and here's the gestational age at which we think it might be valuable, and occasionally, here's patients we might want to do some follow-up. Maybe you want to do a diagnosis early on when you're figuring it out on ultrasound, but then you want to check on the lungs at optimal development, 32, 33 weeks. And so having that written out makes everybody feel a lot more comfortable, and there's a lot less skepticism. Sometimes you pull up a patient, it's revealed that there was a fetal MRI, and half the people in the room are thinking, oh, thank goodness we got this, and the other half are thinking, why did we order a fetal MRI? Whose idea was this? The surgeon's thinking, I didn't need a fetal MRI, but maybe the MFM's thinking, boy, that was great for counseling. So you really need to have sort of everybody come to the table on this and develop these collaboratively. Of course, as the MRI imagers, as the radiologists, we have a lot to add, but it's good to have the whole team there. So just a couple of final slides here. A lot of us aren't at academic settings and have a time dedicated for research, but I don't think you have to be in that setting to see the benefit of the investigational side of this. So every time we're doing a study, we're getting a whole body MRI. That's kind of unique. We're getting a placenta and a brain and a body on every patient, no matter the indication, and we have all of that information. It's just a matter of whether we can find it, if we have a registry, to look back and gain from our experience, and then to learn how to add more value. That's always our goal. What are we adding to the equation, whether it's looking at quantification of some of these things like perfusion or like maturity, or whether it's finding techniques that can tell us things about the vasculature without having to use contrast. There's always opportunities to learn more about what we're doing. People get nervous when you're talking about obstetrics and you use the phrase trial and error. But in reality, a lot of what we're able to gain on optimizing and tweaking our imaging comes from exactly that. And the last point I want to make is that if you're thinking about a program or a center, don't think about a physical space. That's sometimes available. It's great if you have the funding for that, and maybe you can grow into that, but that's not what we're about. So this is Escher's etching of one of my favorite stories, the Tower of Babel. And most of you probably are familiar with that story, right? Civilization put its brightest minds, its most advanced technology, its greatest engineering expertise to do this masterpiece of ingenuity. And they couldn't talk to each other, and the project failed. That could be us, right? That could be us in radiology. We have the best technology in the world, the coolest imaging, but if we can't talk to each other, it's really kind of meaningless. So those are my brief lessons in this amount of time, and I think if you can come away with something, it's that you need to be able to collaborate, to build a team, and build relationships over structures. So what kind of towers do we want to build?